We're chatting with Dr. Ritika Goel, a family physician and assistant professor at the University of Toronto, and she's joined our panel to talk about the intersections of healthcare and social justice. We've been talking about the government's pandemic response and how it's left marginalized communities behind, but this inequity didn't start with COVID. And Ritika, you recently co-authored a piece on the unfinished business of Medicare in Canada, and I just want us to spend a few minutes talking about that. You know, we have this notion in Canada, the sense of pride in our public healthcare system, almost again that kind of smugness we talked about earlier in relation to abortion in our earlier segment. But you outlined some of the critical gaps that we have in our Medicare system, and I wondered if you could tell us a little bit about that and what some of the contradictions are that you see.
Definitely. I think in Canada, we tend to compare ourselves to the US, and really we should be comparing ourselves to countries that have more of a publicly funded healthcare system than we do. So, while we have public funding for some people, for some things, we do not really have a universal system in the way that people like to think of it. In Canada, an estimated 500,000 people are not covered by the Medicare system that are uninsured in one way or another. That includes folks who are new immigrants, people who may be here on various visas like temporary foreign workers that fall in and out of status, as well as those who are completely undocumented despite living in Canada for decades at times. And then we also have a parallel system for many, many folks, including for refugee claimants, including for Indigenous people in this country. And that leads to a lot of challenges. It leads to just lack of familiarity with healthcare providers with these parallel systems. And often it leads to, not the same funding, essentially not the same funding for not the same services. That's just who's covered. And then there's also what's covered. So while we have a public healthcare system, it really only is for hospital and physician services. And we're really the only country in the OECD that has a broad public healthcare system that does not include medications in that system, which is why we so urgently need a national pharmacare program. And we need one that is truly universal and expansive that will cover everybody for all medically necessary medications. So we have to be careful right now while this is being debated that the language of pharmacare does not get taken up in a way that is not a truly universal program. Similarly, we don't cover dental care, optometry, physiotherapy. There's so many services that really are key to health and health care that are currently not a part of our system. And we call this a racial justice agenda for Medicare because, of course, those needs disproportionately fall among racialized communities. When you look at who disproportionately does not have dental insurance, does not have drug coverage, it is racialized communities that are disproportionately impacted.
Pam, when it comes to First Nations in particular, there are vast differences in what they have access to when it comes to Medicare in Canada compared to the rest of the people in the country. Can you walk us through some of the systemic barriers and exclusions there?
Yeah, that's a really good point because it impacts First Nations in two ways. One, in the ways of what their uninsured benefits cover for them and what they don't. And we know from the history and all of the access to information requests that most of the requests for things like dental work or, other kind of health aids were being routinely just dismissed, and the appeals were also being dismissed. And then, we know from the Canadian Human Rights Tribunal case that they were grossly underfunded as well in comparison to what Canadians are funded for similar services. And then many First Nations were falling through the cracks, right? Especially those that were living off reserve or had to get services off the reserve. So some didn't get any services. So, there's been some progress on that front. However, what hasn't really been addressed is even for the things that we are legally covered for is the impact of systemic racism in the healthcare system. So we know from reports like the Royal Commission on Aboriginal Peoples and the National Inquiry into Murdered and Missing Indigenous Women and Girls and inquiries that have happened in coroner's reports and inquests in different provinces. But most recently, the report that the BC did on racism in its healthcare system. And they found, like after interviewing thousands of people and documented hundreds and hundreds of cases in hospitals, in clinics, in every form of healthcare, that the racism in healthcare is Indigenous specific, and within Indigenous peoples of First Nations, Métis, and Inuit, it's First Nations specific. And then within First Nations, women are disproportionately targeted in the healthcare system, and that it limits access to regular treatment systems, and also is a place for surveillance, like what Elle was saying, surveillance and collaboration with police authorities, child welfare authorities, and also a place of violence where forced sterilizations and forced abortions are still happening, where you have doctors, nurses, and police officers in a room saying you have to get sterilized or you don't get your kids back or we'll take your kids. So there's a really like a totally different reality for First Nations people. And it's based on all of these stereotypes that Indigenous peoples are less worthy of care, that we're just drug seeking, that we're bad parents, we're abusing the health system, or we're less capable of taking care of ourselves. And here's what's happened, like the real harm that it causes. So a lot of people think racism or systemic racism, is about political correctness or the woke culture. But systemic racism in healthcare for First Nations people in particular, and especially women, means, you're treated in a very racist and derogatory way. You're actually called names. You can not get service at all. They just make you wait so long that you eventually leave. Like think of what happened to Brian Sinclair in Manitoba. They don't talk to Indigenous patients. They're not getting informed consent or consent at all for procedures like sterilizations. They don't believe Indigenous peoples when they present with issues, or they minimize their concerns. They treat Indigenous peoples as though they should be tougher than everybody else, so their pain management is less than everybody else, and they get rough treatment. They've been sexually assaulted and physically assaulted and suffered injuries in emergency rooms and things like that. So it kills people. Like racism in healthcare is killing Native people. It has been. We've done lots of inquiries on it, but it hasn't improved. And so, that's in addition to what we are or not covered for under Medicare or uninsured health benefits. And that's like the real crisis for us in healthcare.
Just to bring this to a close, we've been talking about, all these racist exclusions in Medicare, but then even more broadly, how, as Pam was just saying, systemic racism is embedded within our entire healthcare system. Everything from diagnosis to treatment to the quality of care to outcomes. I guess I want to hear your thoughts on what you think it's going to take to actually root out this racism in our healthcare system.
Well, two things. So one is that, studies of doctors have shown, similarly to Indigenous people, that actual doctors that have been through like actual medical school believe things like Black people have thicker skin than everybody else, that Black people have lower pain, which is a stereotype that exists from enslavement, that we don't feel pain in the same way. So they've done these questions, and like actual doctors that went to accredited medical schools believe all this, even stuff like giving like Black babies like low APGAR scores because Black babies will have like melanin concentration. They're like labeling. Actually, when I was born, my mom told me, because my dad's white and my mom's Black, and like because my eyes are like they thought that I might have like Down syndrome when I was born, like literally because they couldn't like comprehend, because this is like in England, they couldn't comprehend like a brown baby, and they were like, something's wrong with her eyes. My mom's like, no, like that's just like our heritage, like our eyes look like that, and I'm not 500 years old. I'm not a time traveler. Like this happened when I was born, so it shows that still within medical school education, right? People are somehow picking up and learning these, so not somehow because it's embedded in the system. But then the other thing is, we were talking off the top about, the health minister and others saying, come to Canada if you need an abortion, like we'll open our doors. But of course, migrant people don't have health care in Canada. People without status, people facing deportation, being stripped of status. I worked a case with someone with terminal cancer. And we had to fight for months to get them out of jail. They were on immigration detention and they're not entitled to any medical care. So we've had to fundraise, we've had to go through groups to get somebody like palliative care, because they actually don't have that right. And this is someone with stage 4 cancer that, by the way, progressed because the jail refused to take them to hospital for months when they were bleeding, passing out, losing weight, all of this happening. And it took months for them to even go to the hospital and get a scan. So we know that there's different medical systems in Canada. So again, like much like we'll signal, like we're taking Ukrainian refugees and then like not taking people from countries we're bombing, you know, countries that we are interfering with, not taking brown people and Black people. We'll be like, come here to get an abortion from the States because that makes us look like cool and better. But there's migrant women who are like sexually assaulted by their employers who need healthcare and abortions and all kinds of care and can't get it, right? And people have huge debts, like $500,000 of debt from like going to get medical treatment and not being able to pay for it because they don't have coverage. So, you know, what can we do about that? Like, we actually need to have free and fully funded healthcare. And if COVID showed us anything, the health of the richest of us is only worth as much as the health of the so-called lowest of us, right? Because if somebody gets, as COVID showed us, it only takes one person to get an infection, like, and it can spread to everybody. So it doesn't matter how good the healthcare is for most of us if it's not good for all of us. And like, if COVID showed us anything, it's that we need, everybody needs to have the same level of adequate, accessible healthcare treatment. And if they don't, then the next pandemic and the next and the next, it's going to be the same thing.
We'll end it there. Thanks to all of you. Thanks, Ritika, for joining us today. It was great to have you.
Thanks for having me.